Well, I'm excited to be here. This is fun. It's been a while since I've been to a camp, or not a camp, I'm sorry, AMCAP. That's California Association of Marriage and Family Therapists. That's mostly where I hang out. Anyway, I'd like to get to know you a little bit, kind of get an idea as to your demographics. How many here are MFTs? Okay, so about a dozen. How many social workers? More social workers. Interesting. Any psychologists, clinical psychologists? Okay, half a dozen. And psychiatrists? Okay, any students? Okay, any interns or associates? Okay, one. Awesome. Okay, we've got quite a spread.
This one.
What?
CMHC.
What's that?
Certified mental health.
Oh, okay. Certified mental health counselors. How many? That's neat. Wow, okay. Well, I learned something today. Thank you. Okay. How many of you have treated PTSD in the past? Wow, most of you. Okay. How many of you had training in the diagnosis and treatment of dissociative disorders? Okay, so about 8 or so. All right, that's a good-sized group. How many of you have clients who are dealing with old emotional pain? Duh. Okay, he's got several. All right. How many of you feel that you could use or need some additional training in the diagnosis and treatment of dissociative disorders? Okay, that sounds good. All right, well, great. The title, I'd prefer to hold questions to the end if we can. I've set aside about 20 minutes or so for that. It helps me stay on track. I don't know if I have ADHD, but if people interrupt me too many times, then I start all over again. We don't want to do that. Okay, the title of the presentation is "The Prisoners Shall Go Free: PTSD Challenges and Solutions." Now, the term, or the phrase, "the prisoners shall go free," is from Isaiah. It refers specifically to the millennium, but it also applies to people who have PTSD, because a lot of them feel like they're prisoners. I had a client recently who said, "I feel like a prisoner in my own mind." And I know in dissociated systems, the alters feel like they are prisoners. So our job is to help the prisoners, to set the prisoners free. The term post-traumatic stress disorder was coined in 1980 as a result of the Vietnam War and became part of the DSM at that time. It's a condition that was recognized as far back at least the Civil War. Where's my clicker? I need to start clicking. All right. They called it soldier's heart back in the Civil War, or irritable heart, or nostalgia. In World War I, it was called shell shock. World War II, battle fatigue and combat fatigue. The Vietnam War, it started off as the Vietnam disease, then post-Vietnam syndrome, and was later changed to post-traumatic stress disorder. Now the military is calling it combat stress, so we're kind of going back. Other names have included traumatic neurasthenia, railway spine, war syndrome, gross stress reaction, old sergeant syndrome, neurocirculatory asthenia, cerebral medullary shock, simple continued fever, disordered action of the heart, buck fever, and Swiss disease. The plethora of names that they've called it in the past is, in my opinion, is one of the challenges. Social denial. Between wars, we forget that there is such a thing. We have to invent a new name with each war. After a war, people want things to go back to normal and expect the Veterans Administration and families of the veterans are going to take care of them. Out of sight, out of mind. Put the war behind us. The problem is many of the veterans bring the war back with them, as you're well aware. Intrusive memories, flashbacks, nightmares, anxiety, panic attacks, depression, anger, explosive rage, hypervigilance, etc. Part of the soldier is still stuck in the war. Our job is to help them get unstuck. With the recent wars and shame over how the Vietnam veterans were treated, our veterans now are being treated with a lot more respect, although the treatment is somewhat still lacking. Individual denial is another challenge. Our GIs are tough. They don't want to admit that they have any weaknesses, just like the missionaries that were talked about this morning. Many active duty veterans do not seek treatment for that reason, and also from the realistic fear that doing so might end their military careers. There's also a social stigma attached to PTSD that could affect relationships and their careers outside of the military. A 2014 Congressional Research Service study reported that only 50% of veterans with PTSD seek treatment. and only 50% of them receive, quote, minimally adequate treatment, unquote, which is 8 therapy sessions within a 14-week period. Also, there is some resistance to treatment by some veterans who don't want to lose their disability income. I've run into that recently. It came as a surprise to me. A more aggressive campaign to educate the public about PTSD and treatment would go a long way toward eliminating both societal and individual denial. So what's the extent of the problem? Well, the Veterans Administration published a report titled Screening for Post-Traumatic Stress Disorder, PTSD, in Primary Care, a Systematic Review. It's by Spoon et al., January of 2013. They claim, they're talking about just Americans in general, they claim that most Americans will experience a traumatic event in their lives, and approximately 8% of the general population will develop PTSD. 10% of women and 5% of men. Women seem to be more susceptible to PTSD. At a little over 300 million people, that equates to about 24 million Americans who are going to suffer from PTSD. That's an awful lot. It's a horrible number. What about the rest of the world, especially war-torn countries? What's the incidence of PTSD in those areas? War is the primary cause for PTSD. As long as we have war, we're going to have PTSD. The VA reports in this report reported 400,000 veterans with PTSD on their rolls. Approximately 20% of those returning from the Middle East wars are reported to have PTSD. The RAND Corporation estimated that number to be about 300,000, and most have received no treatment. 30% of the Vietnam War vets were diagnosed with PTSD. And these rates are a much higher rate than the general population. The percentage among women vets is higher than men, due in part to being raped by fellow soldiers. They go on to say in this report, quote, those who suffer from PTSD often have diminished functioning and poor quality of life, as evidenced by elevated rates of suicide, hospital admissions, poverty, and unemployment, unquote. They have more health problems, including age-related problems that develop early. And they use much more in the way of medical resources. In June of 2013, 5 months after the VA study, conflicting numbers of Middle East war vets with PTSD was released in a 300-page report after a 4-year study by a 16-member committee with the Institute of Medicine under the direction of Congress. They claim there are 650,000 veterans from the Middle East wars who have PTSD. Divide that number by the 2.2 million GIs who have served in those wars, and you get about a 30% rate, the same as from the Vietnam War. Whatever numbers you use, they're really high and represent an incredible amount of suffering, as you're aware with the clients you have that have PTSD. The study also reports that neither the VA nor the Department of Defense are tracking patient outcomes or have tracked patient outcomes, so they don't really know what works and what doesn't. The costs of PTSD to society can be divided into human costs and economic costs. The symptoms of PTSD cause tremendous suffering in those who have it. That's the beginning of the human cost. The relationships are strained. Normalcy for most of them is unattainable. Their spouses and children, it affects the families, their spouses and children have to adjust to a life with someone who is unpredictable, depressed, anxious, could become violent at any time, and may have explosive rage. This is not the same person who went off to war. Some cannot re-engage in life. Families with a PTSD parent show increased anxiety, unhappiness, marital problems, and acting out in children. Divorce rates are higher among vets with PTSD. Friends may give up on them. Their old job may not be there, or they may not be able to do it anymore. Poverty and dependence add to their depression and feelings of inadequacy. Alcoholism and drug addiction are high in an attempt to self-medicate the pain. The VA reports more than 130,000 veterans are homeless on any given night. Many are women. Women have higher rates of PTSD than men, divorce, and homelessness. Mickey DeHaren is not an isolated example. He was a firefighter in New Brunswick, New Jersey, and served as a military police officer in Iraq. He can no longer work as a firefighter, his dream job since age 7. He's on his second marriage since returning from war. He spends most of his time on the patio drinking beer and smoking cigarettes. He spends his nights outside wrapped in a blanket on an office chair, afraid to sleep with his wife for fear he might hurt her again in his sleep. She says, it's like he's not even part of the family most of the time. His panic is so bad he can't even ride in a car 1 hour to the VA hospital for treatment. Suicide rates are high. We lost 58,000 GIs in the Vietnam War and 60,000 since then to suicide. So the rate of suicide, we lose more soldiers to suicide than we do to combat. More Vietnam soldiers have killed themselves than were killed in the war. We're currently losing an average 22 veterans and 1 active duty GI to suicide every day. For the past couple of years, more active duty military have killed themselves than have died from combat. Again, it's the similar statistics to Vietnam. A typical story was carried by the Associated Press in 2012. Quote, Kim Ruocco, widow of Marine Major John Ruocco, a helicopter pilot who hanged himself between deployments in 2005, said he was unable to bring himself to go for help. He was so afraid of how people would view him once he went for help. She said in an interview at her home in suburban Boston, he thought that people would think he was just trying to get out of service, or get out of deploying, or trying to get out of service, or that he just couldn't hack it, when in reality he was sick. He had suffered injury in combat, and he'd also suffered from depression and let it go untreated for years. And because of that, he's dead today. The economic costs of PTSD are staggering. Billions of dollars per year. In 2008, the RAND Corporation reported costs for medical care, lost productivity, and suicide from veterans was $2 to $3 billion per year. In 2005, 200,000 veterans were receiving disability benefits of $4.3 billion per year. 25,000 of those were World War II veterans who were still receiving benefits from PTSD-related disability. Another challenge, another challenge is some who have PTSD are not diagnosed with PTSD. They are diagnosed and treated for something else. That's why the VA developed that particular screen that I mentioned, used by primary care physicians. I've noticed myself recently that I've had more PTSD clients showing up, or I've become more aware of them actually, probably because I'm screening more for PTSD. Many are being treated by mental health professionals for anxiety and depression, or whatever the presenting symptom is. I would recommend a PTSD screening for anyone who comes in with any of the PTSD symptoms. They don't have to have all of them. Long delays in receiving treatment is another challenge. We've all heard recently the horror stories about how the VA has put people on waiting lists until they die. Delays in beginning treatment as well as receiving prescriptions is common. Last year, USA Today reported that 851,000 veterans are still waiting to hear about their disability claims. I don't know if calling Congress and senators would help, but it probably wouldn't hurt. Children are not immune to PTSD. According to the VA's National Center for PTSD, quote, studies have shown that as many as 100% of children who witness a parental homicide or sexual assault develop PTSD. Similarly, 90% of sexually abused children, 77% of children exposed to a school shooting, and 35% of urban youth exposed to community violence develop PTSD, close quote. According to the U.S. Census Bureau, 23% of Americans are under age 18. According to the National Comorbidity Survey Replication Adolescent Supplement, 5% of them develop PTSD before age 18. That's about 3.5 million children just in the United States who have or will develop PTSD. Besides traumatic events, they list other risk factors for children developing PTSD to include, quote, female gender, previous trauma exposure, pre-existing psychiatric disorders, parental psychopathology, and low social support, unquote. In children and adolescents, PTSD can present itself differently than in adults. All ages have symptoms of re-experiencing the trauma, avoidance, numbing, and arousal. Elementary age children typically do not have visual flashbacks or amnesia. They do have time skew where they remember the sequence of events wrong, and omen formation where they believe there were warning signs that they need to look for. They also tend to show post-traumatic play or reenactment of the trauma in play, drawings, or verbalizations. And the DSM-5 now has separated out different criteria for children under the age of 7. Adolescents tend to react more like adults, however, plus they're more likely to show reenactment of the trauma by incorporating aspects of the trauma in their daily lives. They just kind of reenact it. Being sensitive to the age-related differences can help with an accurate diagnosis. The bottom line is PTSD is a huge problem here and worldwide. It affects millions of people, causes an incredible amount of suffering, has massive human and economic costs, and doesn't seem to be getting much better. Colin Ross, in his MD, in his book, The Trauma Model, claims, quote, "It is possible psychological trauma is the #1 public health problem on the planet." I tend to agree. Okay, so how's PTSD being treated? Okay, for this I'm going to learn heavily on Matthew Friedman, MD, PhD, his book, Post-Traumatic and Acute Stress Disorders, the Latest Assessment and Treatment Strategies, 2006. There are many treatment options available, as I'm sure all of you are aware. The most common involve individual therapy, group therapy, and medication. Variables for selecting a treatment would include the client's age, the type and severity of the trauma, and the presenting symptoms, of course. Psychoeducation can help normalize the condition and lower fear of the unknown in both the client and the family. It can remove self-blame and self-doubt, correct misunderstandings, and enhance clinician credibility. Individual therapy allows the client to work on specific issues to reduce the symptoms and improve relationships within the home and outside the home and functioning. Dr. Friedman lists 3 main types of therapy being used today. Cognitive behavioral therapy, CBT, based on the principles of learning theory and cognitive psychology. Eye movement desensitization reprocessing, EMDR, is based on the theory that rapid eye movements reprogram the brain's processing of traumatic memories. And psychodynamic psychotherapy, based on the theory that symptoms of PTSD result from repressed memories of the traumatic event, and that the patient's insight into those memories and their impact on symptoms will help restore psychological balance, unquote. Insight is not always curative. I'm sure you found that out. CBT confronts distortions in thinking, like the environment is dangerous or I am helpless. It attacks conditioned responses and automatic thoughts. The ultimate goal is to normalize abnormal thoughts, feelings, and behaviors. There are several different CBT approaches. Each of them has a carefully scripted manual and requires 9 to 16 sessions. According to the current published literature, CBT is the best treatment overall for PTSD. My concern is, does this treat the cause of PTSD, or is it treating just the symptoms? He goes, I'll quote him here, "Proponents of EMDR believe saccadic eye movements reprogram brain function so the emotional impact of the trauma can finally be completely resolved." Unquote. The client thinks about how many of you are trained in EMDR? Okay, so if I say something wrong, tell me after. The client thinks about the traumatic memory while moving back and forth between the 2 hemispheres of the brain. The results seem to be the same even when eye movement is not involved. If alternating sound or physical sensations from one side of the body to the other seem to have the same effect. EMDR has some similarities to CBT. Some studies show that CBT is more effective than EMDR. Some say that EMDR is more effective, but they kind of average out, or that they're equally effective, According to the published literature, both have significantly reduced PTSD symptoms in more than 50% of the subjects. Bessel van der Kolk is a big proponent of EMDR. He's a psychiatrist back in, I think, Boston, and he's done more research and writing on the subject of PTSD than anybody else on the planet. He's a walking encyclopedia, and he uses words this big. I have to read his stuff 2 or 3 times to understand it. Anyway, he said that studies show that EMDR seems to be more effective with acute trauma than with chronic trauma. Okay, again, is this treating just the symptoms, or are they actually treating the cause of the issues? Psychodynamic psychotherapy has been used to treat PTSD for over 100 years. So it hopefully has a reasonable track record. The basic theory is that people repress or push intolerable affect and memories out of conscious awareness in order to maintain a psychic balance, to survive and function normally. These traumatic memories are still powerful enough to contribute to symptoms like PTSD. Through awareness of how repressed memories have produced symptoms, clients gain control over the repressive defense and reduce symptoms. Only one study was mentioned, and he claims, quote, it effectively reduced PTSD intrusion and avoided symptoms by 40%, unquote. The weakness that I see in this particular approach, psychodynamic psychotherapy, is that if you're only working on repressed memories and you're ignoring dissociated memories, the potential for healing is really limited. I'll talk about that more a little bit later. Okay, group therapy, especially if it's led by a peer counselor, gives support, a feeling of camaraderie, practical solutions to daily challenges, and lifts the feeling of isolation. They know they're not alone. That's critically important, particularly with the soldiers, but anybody who has PTSD. They need to know that they're not alone. When the groups are run by a clinician, different modalities can be used like CBT or a psychodynamic approach. In both cases, survivors learn about PTSD and help each other, so they get psychoeducation involved. Group therapy is effective and popular, especially when all members have survived the same type of trauma, whether you have soldiers or whatever it might be. Quote, children and adolescents with PTSD face additional treatment challenges based on the developmental stage when the trauma occurred and the impact of that stage on how they were able to put what was happening into some overall context. Family and school involvement appears critical to treatment success. I hadn't considered involving schools before, but it's probably a good idea. CBT also seems to be most effective with this younger population, although there's been little research done. Okay, medication. Most of us aren't really involved in medication, but it often helps reduce symptoms, and in my opinion, but I don't believe that it treats the underlying cause. If you have pneumonia, you take penicillin, it treats the cause. If you have depression, and unless your depression is a biomedical issue, chemical imbalance, then it's may not be treating the cause. Dr. Friedman considers SSRIs to be the first-line treatment for PTSD, and he lists 3 reasons. 1, they have a broad spectrum of effect against all PTSD system clusters. They're effective against many comorbid disorders, and they're effective against associated symptoms such as impulsivity, aggression, and suicidal thoughts. They're especially helpful when a client has a comorbid condition like a depressive disorder, a panic disorder, social phobia, or OCD. Only 2 SSRIs have been approved by the FDA for treating PTSD. Paroxetine and sertraline, if I pronounced them correctly. Second-line medications include venlafaxine, prazosin, TCAs, and MAOIs. Anticonvulsants and atypical antipsychotics are considered third-line medications due to the side effects. Benzodiazepines and antipsychotics are not recommended for treating PTSD due to the side effects and the lack of evidence that they actually help. Okay, there are many assessment instruments available for acute stress disorder and PTSD. They are divided into 3 main categories: assessments of trauma, criteria A, diagnostic instruments, and tools that assess PTSD symptom severity. Those are criteria B, C, and D. Most are self-report. A few are structured interviews. Some are general, assessing all traumatic experiences. Some are specific, like childhood trauma, war, rape, that kind of a thing. Some are designed for clinical use, some for research. There are some adapted specifically for children that are developmentally sensitive and use smaller words so that the children can understand them. Most of them have good reliability and validity. Giving questionnaires to children younger than 6 is not recommended. I prefer just to use the DSM-4 criteria as a self-report. That works for me. Okay, the most significant change in my mind regarding PTSD in the DSM-5 is moving it away from anxiety disorders to a new category of trauma disorders. Back in December of 2009, I wrote the DSM-5 committee and asked them to move PTSD from anxiety disorders to dissociative disorders. I did not get a response. Are you surprised? Bessel van der Kolk, I wrote Bessel van der Kolk. I was hoping to engage his support in this venture. But I emailed him to do the same thing if he agreed that it was a dissociative disorder. He does not respond to emails, but he sent me an email, which I was thrilled to get. He said, quote, "I know what you're talking about. It is a delicate process and an uphill battle, but I agree with you that if therapists do not recognize the dissociative nature of traumatized patients, it will be hard to help them. The DSM-5 committee consists entirely of epidemiologists, a tough group to argue dissociation with," unquote. Since at least 1980, PTSD has been treated as an anxiety disorder, presumably because anxiety was a prominent symptom. Anxiety disorders can't be cured. They're just managed. They're treated with medication and sometimes with therapy. Since people were told, since therapists, the therapy world was told that PTSD was an anxiety disorder, that's how we've been treating it. And along with that, thinking that it can't be cured. The DSM-5 committee now admits that it's not an anxiety disorder. That tells me that the mental health profession has been treating PTSD by their symptoms. They've been treating it symptomatically. They haven't been treating the cause. And I think that's the primary reason that we've been getting such bad results, with PTSD over the years. The DSM-5 committee now admits that we have been treating PTSD for what it is not. When you treat a condition for what it is not, is it any wonder you don't get good outcomes? In my opinion, that's why those who have been treating PTSD as an anxiety disorder haven't been getting the outcomes that you really wanted and that the clients wanted. Treating it for the wrong thing has, in my opinion, been a huge challenge. That's another challenge. Treating it for the wrong thing. We can overcome that challenge by treating it for what it is. So what is it? Okay, I propose that PTSD is a dissociative disorder, pure and simple. When you treat PTSD as a dissociative disorder, you're treating the cause. You treat the cause, the symptoms go away. Again, Bessel van der Kolk said, quote, "If therapists do not recognize the dissociative nature of traumatized patients, it will be hard to help them," unquote. PTSD clients are traumatized clients. He also said, quote, "The post-traumatic syndrome is the result of a failure to heal all wounds. The memory of the trauma is not integrated and accepted as part of one's personal past. Instead, it comes to exist independently of previous schemata, i.e., it is dissociated," unquote. I contend traumatic memory and emotional pain are often dissociated as a dissociative disorder. I've been treating PTSD as a dissociative disorder for 20 years, and I get consistently good results. 20 years ago, I learned a very effective treatment modality for dissociative disorders, including PTSD, called trauma conversion therapy. The idea is you convert the trauma into memory by releasing the pain. Once the pain's gone, the symptoms are pretty much gone. And I learned it from a therapist in San Bernardino, California, Mel Osborne, who has since retired and passed away. There are other therapists in California who are using this technique effectively, so that demonstrates it's the technique, it's not the therapist. It has 5 major advantages over other trauma therapies that I've looked at. Number 1, it's fast, usually less than 20 sessions, which qualifies as short-term therapy. HMOs and clients like that. I average about 8 sessions with most of my clients. 2, the client does not have to relive the trauma through abreactions. The old pain is processed internally. Someone coined the term silent abreaction. I wish I know who it was so I could give him credit, but I love the term. It's processed internally, a silent abreaction. The idea is to heal the trauma, not relive it. I don't want my clients reliving the trauma. Number 3, the therapists do not have to listen to the gory story, thereby avoiding vicarious traumatization and therapist burnout. There's a lot of therapist burnout with trauma therapists. You don't have to. I don't listen to the details. I don't want to hear it. Bessel van der Kolk said one time, I heard him do a presentation, he said the best advice he ever got from his supervising therapist, whoever it was, or trainer, was to, when you're dealing with people with trauma disorders, put your voyeuristic tendencies on hold. By using this technique, you don't have to listen to the gory story. I mean, it's really cool. I had a fellow from Korea. He had a PhD in pastoral psychology, and he's working on becoming an MFT. And he got so excited when I told him, you don't have to listen to the gory story. Anyway, I've trained him. He's now teaching at a university in Seoul. And I'm excited for him to actually do a research project proving the validity of this thing. Number 4, the client does not experience a therapy hangover after sessions, nor a significant drop in functioning. And that's always been a real problem with in trauma therapy, is that people, you get them to tell their story over and over and over again until they feel better, and they usually feel worse. Number 5, it is consistently effective when the client stays to the end of treatment. And that's the trick. With a lot of military and veterans, they don't want to be there. They take just enough of the treatment until they start feeling a little better, then they duck out. So that's a challenge. Okay, I have some case studies that I'd like to mention real quick. I had a former Marine come in, it was about a year ago, with PTSD. He was 31 years old, married, had 3 children. He'd been in the Marines for 4 years, spent 3 months in Iraq, received a medical discharge, and had been out of the military for 4 years. When he came to me for the first session, he hadn't slept in 2 days. He had chronic depression and anxiety, explosive anger, barricaded himself in the house, covered all the windows, isolated, slept with a gun under his pillow, didn't feel safe. He had hypervigilance, poor sleep, poor concentration, flashbacks, and nightmares. He was a mess, and he was feeling detached from other people and hard to make decisions, had avoidant behaviors, unable to work. He was taking Zoloft and Depakote at the time. The VA offered him medication, group therapy, and the wonderful advice that he would just have to get used to it. He would not be able to work as a police officer, his lifelong ambition. Okay, after the first session, he called and said he'd slept the whole night. When he came in for the second session, he reported that he was sleeping better, few nightmares, the depression was gone, anxiety was low, and he'd stopped taking his medication. The third session, he reported that he was sleeping normally. He didn't have any more nightmares or flashbacks. He had little anxiety, put his gun away. He was no longer isolating or barricading the house. He was more decisive. He could talk himself down when he started to get anxious. He had a small reaction to gunshots now, and he would talk himself down and get back to reality very, very quickly. After the third session, he was pretty much back to normal and signed up for some college classes. I had a female, and that's the norm. That's not the exception. That's the rule. That's usually how it works. It goes very quickly. When you treat the source of a problem, you get rid of the symptoms very quickly. I had a female client with PTSD, 40 years old, married. She was raped at ages 13, 19, and 21. Her house burned down at age 13. Her first husband was abusive. Within a 4-year period of time, her father died, her uncle died, her brother died, and her 6-year-old son was taken away and adopted out. She had chronic anxiety and depression, panic attacks, mood swings, poor sleep, hypervigilance, migraine headaches, distressing memories, dreams and flashbacks, strong physical and emotional reactions to memories of the traumas, avoidant behaviors, hard to trust, loss of interest in things, feels estranged from people, and has forgotten parts of the traumas. And she was not taking any psychiatric medications. Okay, we had 4 sessions over a 2-month period. All of her PTSD criteria were resolved. Her anxiety and depression were gone. She was sleeping well. The house behind her caught on fire, and it didn't freak her out, which was really kind of cool. She handled it well. The migraines were gone, and her concentration was a whole lot better. Annette Compton is an MFT in California. We share an office. She's had good results with this type of therapy as well. She told me recently about a Vietnam vet with PTSD that she worked with. He's 63 years old. His third wife reported his PTSD symptoms were getting worse, which is very typical. He presented with depression, isolation, flashbacks, nightmares, avoidance of activities and people, survivor guilt. He was the only survivor of an attack in Vietnam on his company. After 3 sessions, he told me he had felt more relief than after 40 years of treatment from the VA. They gave him medication and group therapy. She reported that he was now talking about thoughts and feelings for the first time, addressing the grief of military losses, his best friends, survivor guilt, and the loss of his father when he was 17. He's had a significant reduction in symptoms because she was treating this as a dissociative disorder. I taught her how to do this. She's my poster child. She had another military-related PTSD case from a 50-year-old male, or with a 50-year-old male. He presented with poor sleep, with depression, restlessness, discontent, flashbacks, recurring nightmares, memory loss, blocking of traumatic events, avoidance of events, activities and places that arouse recollections of the trauma, and marital problems. He also had chronic elbow pain from his military service. So he was in Special Forces, and he would lay on his stomach and elbows, pointing his weapon at a target for up to 8 hours at a time. So both of his elbows were giving him problems. After 6 sessions over 3 months, treating this as a dissociative disorder, the PTSD symptoms were resolved, the elbow pain went away, and the marriage has significantly improved. Susan Oldham, MFT, also in California, has used this technique effectively. In fact, she is so excited about this. When she got a new car, she got a license plate that said TCT works. She's a hoot. She has a PhD in biochemistry, taught chemistry at USC for 20 years. In her spare time as a concert violinist, she plays in the symphonies in around the Southern California area. And she's also an MFT. I'm not sure she did that in her spare time or what, but she is a kick in the head. She was licensed as an MFT back in the mid '60s. I don't know how old she is, but I think it's about 100. But I love her. I absolutely love her. She's a gas. Anyway, she had this client. She treated a 73-year-old woman with PTSD who had early childhood traumas and problems with doctors when she broke her hip. That was what gave her the PTSD. Treatment by medical people before and after her surgery she believed was rude, not responsible, and borderline incompetent. She felt helpless and fearful. She had distressing recollections of the event, intense psychological distress when reminded of it, and she avoided things that reminded her of the event. She's lost interest in activities, felt estranged from others, difficulty concentrating, and was irritable. She was seen 9 times over 6 months. There were 6 alters who were worked with. All 6 had absorbed anger, fear, and memories of the hospital experience. Some had physical pain. All of the symptoms were resolved. That was 9 sessions over 6 months. It has been my experience that when PTSD is treated as a dissociative disorder, it can be healed, and it goes quickly. I consider the biggest challenge of all is recognizing dissociative disorders and how significant they are. We're not taught how to diagnose and treat dissociative disorders in graduate school. MFT, social workers, etc. Talk to a psychiatrist. I work in a psychiatrist's office 3 days a week, and I talked to a psychiatrist last week, I think it was. I mentioned this to him, and he said, they didn't teach us that stuff in our residency. They don't. It's listed in a book under abnormal psychology. Yeah, there is such a thing, but you're not really taught how to diagnose it or how to treat it. That's a big hole, in my opinion, in the training of psychotherapists. And I better not say that. Okay. You have to have specialized training in order to learn it. That's the bottom line. I took that training 20-something years ago from Mel in San Bernardino, and I've been using it since. I absolutely love it. I'll go one step further beyond saying that PTSD is a dissociative disorder and say that I believe dissociated pain causes or contributes to about 2/3 of the disorders listed in the DSM-4. That's a pretty bold statement, but after 20 years, I believe it.
Please say it again.
I believe that dissociated pain causes or contributes to about 2/3 of the DSM-4 disorders. Okay? It's a comorbid condition in a lot of them, but I think it causes a whole bunch of them. Okay, for years I'd wondered why psychotherapists did not consider PTSD to be a dissociative disorder. It hit me recently, about a month ago, that they're not trained in how to diagnose a dissociative disorder, so they don't know how to recognize one, so it makes perfect sense that they would not recognize PTSD to be a dissociative disorder. Does that make sense? Okay. 3 different sources, including the Sidran Institute, have quoted the same statistic. The average time a person with a dissociative disorder is in the mental health system before being properly diagnosed is 7 years. 7 years. So that's an indication that psychotherapists don't know how to diagnose a dissociative disorder. I mean, there are some who do, and eventually they get diagnosed. But what happens in the meantime? They're diagnosed with something. Maybe they're being diagnosed with something they don't have. And if they're being treated for something they don't have, they may be being mistreated. They're not only not getting the treatment they need, but they may be getting treatment they don't need. I'm thinking particularly of psychotropic medications. Anyway, I digress. Okay, there are several tools available to help diagnose dissociative disorders. Am I supposed to click on something? Where are we? Okay, we'll go ahead and do that. Nope, we're not there yet. Sorry about that. Screening tools like the Dissociative Experience Scale and Adolescent Dissociative Experience Scale. There's a copy of each in your packets. It was developed by Dr. Frank Putnam and some other people. It's not copyrighted. They want everybody on the planet to use it. It's considered valid and reliable. It's used mostly in research purposes. For research purposes, it lists a whole ton of dissociative types of symptoms. It'd be really helpful for you to become aware of it. I don't use it in diagnosing clients because it's not a diagnostic tool. Structured interviews like the DDIS by Colin Ross. It's the Dissociative Disorder Interview Survey. Yeah. That one is a structured interview. That's supposed to actually diagnose people, diagnose PTSD. No, it's supposed to diagnose dissociative disorder. Sorry about that.
Can you repeat which interview that is, please?
The DDIS. It's by Colin Ross, COLINROSS. I'll have his website up here at the end. But it's the Dissociative Disorders Interview Survey. DSM criteria is another way that you can diagnose dissociative disorders. A sodium amytal interview. Don't know if anybody has ever gotten involved in any one of those. So it's sodium pentothal. It's related to sodium pentothal truth serum. So you give somebody a shot of sodium amytal and you do a diagnostic interview and you can determine that they have a dissociative disorder. The last time I checked years ago, it was like $1,000. A lady called me up one day and said, "Do you diagnose dissociative disorders?" And I said, "Yes." She said, "Well, my psychiatrist in Corona wants to diagnose me, and he wants to use the sodium amytal, doing a sodium amytal interview, and he wants to charge me $1,000. And I said, "Well, I'll do it for a lot less than that." You know, it's really simple, actually. What I use is the idiomotor interview. This is the fastest and, in my opinion, the best way to diagnose a dissociative disorder. It's really clean. Okay. At this point, I want to define some of the terms that I'm using and will be using. My definition for dissociation is really simple. It's tuning out to what's going on around you. Daydreaming is a simple example, or being engrossed in a book or a movie. It's a normal, natural thing that people do, and it's subject to conscious control. You can start and stop at any time you want. A dissociative disorder, or what's referred to as pathological dissociation, is a structural splitting of the personality as a survival mechanism, creating alternate personality states, ego states, alters. There's lots of different terms that have been used for it. It's not subject to conscious control. Memories and feelings can also be split off. They're absorbed by these alters are split off. Memories that are split off can cause amnesia for the event in the client. So the client may not remember the traumatic event, or may only remember parts of it. Intense feelings that are split off can be triggered by events to come up and cause overreactions, like panic attacks, explosive rage, that kind of a thing. I call it the Hulk syndrome. Frank Putnam, MD, in Dissociation in Children and Adolescents, 1997, pulls together some definitions from different sources trying to define dissociation. From the DSM-4, quote, "The essential feature of the dissociative disorders is a disruption in the usually integrated functions of consciousness, memory, identity, or perception," unquote. My interpretation of that is consciousness, memory, identity, and perception can be unintegrated as a result of trauma or split, like into altered states of consciousness. From Ernest Hilgard, 1986, quote, "A special form of consciousness such that events that would ordinarily be connected are divided from one another," unquote. Split, again. From, I hope I pronounced this right, Louis Jolyon West, 1967, quote, "A psychophysiological process whereby information, incoming, stored, or outgoing, is actively deflected from integration with its usual or expected associations." Dr. Putnam kind of sums it up. Quote, "Dissociation involves a failure to integrate or associate information and experience in a normally expected fashion," unquote. Okay, that makes sense. Alters, I want to define what an alter is, sort of. Alters or alternate personalities are part of the personality that have split off as a result of trauma, absorbed physical and or emotional pain, and have become reservoirs of old pain. That's the key to this whole thing. The alter is a reservoir of old pain. The idea is to go in and drain the swamp, so to speak. Empty that reservoir of old pain. Until you do that, the client's not going to get better. They function somewhat autonomously. Dr. Putnam explains, quote, "Alterations of self and identity constitute a core symptom of pathological dissociation. All of the dissociative disorders include forms of identity alteration," unquote. And then he further says, the first alter personality states, the first one that splits off, of MPD patients are often reported to have arisen in the context of an overwhelming traumatic event and to have had immediate survival value. Well, yeah, that's the whole point. It's just the dissociating is a survival mechanism. He further states, "Alter personalities are real. They do exist, not as separate individuals, but as discrete dissociative states of consciousness," unquote. Okay, so alters are real. I don't really care if they're separate individuals or not. All I know is when I treat them as though they are separate individuals, the client gets better. Okay, dissociated memories. Those are memories that are absorbed by the alters and they may not be available to the client. Repressed memories are memories that the client absorbed and pushed down inside. They can be recalled by the client. That's the part that the client has to process. Trauma. It's a subjective impact on a person by a traumatic event. It's what the client thinks or the individual thinks about it, not what anybody else does. Colin Ross describes it as this, quote, "There is an extreme event and an extreme response," unquote. He goes on to say that neglect is at least as traumatic as abuse, and trauma to a person's attachment system during childhood is what really counts in trauma therapy. Okay, trauma disorder. Is anyone, my definition, trauma disorder is anyone who has had a painful experience in their life and it's still affecting them in a negative way. Thoughts, feelings, behaviors. Triggers are outside stimuli that cause an alter to react physically or emotionally. The Vietnam vet's walking down the street, car backfire, he's back in Vietnam, jumps behind a bush. That's a trigger, that's an extreme reaction. Switching, alters coming out and influencing or taking over control of the body. The inner mind, that's my name for the subconscious mind. It's part of the human mind that's outside of conscious awareness. It's like an onboard computer, able to access memories and alters and do a diagnostic of the system. Comorbidity is the presence of 2 or more DSM-4 diagnoses. A dual diagnosis is the presence of a substance use disorder with another DSM-4 disorder. Deep relaxation versus hypnosis. Dr. Ian Chand of Loma Linda University was the fellow who explained to me the clinical difference. He said that it's who's in control of inducing the deeply relaxed state is the difference. If, like, you may have seen stage hypnosis, where the hypnotist says or does something and the person keels over. He's inducing the state, that deeply relaxed state. That's classical hypnosis. If the therapist kind of talks the person through, like a progressive muscle relaxation or guided imagery, that kind of a thing, and the client relaxes themselves, that's deep relaxation. The client's in charge or in control of relaxing themselves. He claimed that Loma Linda University does not allow hypnosis on their campus. They don't want people controlling the minds of their followers, parishioners, whatever you want to call them, their members. But they do allow deep relaxation, so they recognize the clinical difference. And he's trained in Ericksonian hypnosis and a whole bunch of other stuff. Okay, so how do you recognize a dissociative disorder? What does it look like? Okay, you could start with a DSM-4 or 5 criteria for dissociative disorders. Quote, disruptions in the normal integration or splitting, my words, of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. That's out of the DSM-5. See, so body representation, if there's a disruption in body representation, could that be body dysmorphic disorder? If so, is it possible a dissociative disorder could be causing a body dysmorphic disorder? It would be worth further. It's worth further It's worth further assessment if a client has any of the following issues. I consider these to be red flags. From Dr. Putnam, any dissociative symptoms. That's right off the top. Dr. Putnam lists anxiety, depression, unresponsive to treatment, substance abuse, psychotic symptoms, self-destructive behaviors, migraine headaches, frequent changes in employment, or repeated victimization. If any of your clients have any of those things, it would be worth assessing for dissociative disorder. From the Trauma Recovery Institute, they list identity confusion, including sexual, memory loss or gaps, losing time, recurrent nightmares, flashbacks, out-of-body experiences, feeling dazed or zoned out a lot of the time, command hallucinations, self-cutting, pseudo-seizures, phobias, extreme shyness, sexual inhibitions or fears, emotional numbing, personality changes, conversion symptoms, traumatic grief, acute stress reactions, and disturbing voices or internal debate. Then there's some others that I've added to the list. Intense acute or chronic feelings. Tell me about your history of anxiety, your history of depression, your history of anger, childhood, teenage, adult years. Have you experienced a lot? How much are you feeling currently? That kind of a thing. Overreactions. If an alter pops up and dumps his 100 pounds of anger on top of a 1 pound event, you have a big explosion, a big overreaction. Obsessive thoughts, compulsions, addictions, feeling out of control. If somebody has a dissociative disorder and alters are coming out and affecting thoughts, feelings, and behaviors, they're going to feel out of control. Changes in handwriting. There's a sheet in your thing it's 1 page out of a journal from one of my clients. It has several examples of changes in handwriting. It's really dramatic. Most of the time, it's not that much. But if somebody likes to journal, ask them to bring their journal in. You don't have to read it, just look at it. See if there's changes in handwriting. If there is, it indicates there may be some dissociative stuff going on. The other alters are coming out and doing some of the writing. Night terrors. That's somebody having a nightmare and an alter popping up in the middle of that nightmare thinking it's a real event. You're working with a dissociative disorder there. Phobias in general. If an alter is triggered to come out as a result of a specific trigger, whether it's like a cat or spiders or whatever it might be, heights, etc., even claustrophobia, there may be some dissociative stuff going on there. Sleepwalking, eating, sleep sex, that kind of a thing. They don't remember doing it. It's usually the alter taking the body out for a spin. Once the person's asleep, they feel comfortable. Okay, I can take the body out for a spin. What was it? Okay, I'll come back to it if I think of it. Anyway, sleepwalking in a child, in young children, is normal. In an adult, it's not. So if somebody sleepwalks as an adult, you might want to check them out, see if there's an alter in there doing that. Okay, these symptoms are sometimes driven by old dissociated pain. Now, the following diagnoses from the DSM-4, I just pulled out a few, have a dissociative component, and they might be driving the symptoms, maybe contributing to the symptoms. Substance use disorders, somatoform disorders, personality disorders, gender disorders, sexual disorders, mood disorders, eating disorders, anxiety disorders, factitious disorders, some sleep disorders, some amnestic disorders, impulse control disorders, some adjustment disorders, reactive attachment disorders, that's always trauma-driven, disruptive behavior disorders, sometimes schizophrenia. What's left? Any of your clients have any of that stuff going on? Assess them for a dissociative disorder. Let's take a closer look at a few of them. Anything that's driven by trauma can be anyone? Okay. Where are we here? Okay. Anyone with a trauma history can and should be assessed for a dissociative disorder, because anything that's driven by trauma can be driven by old dissociated pain. That's the bottom line. Addictions. I think most of us would agree that addictions are a form of self-medication. They want to numb the pain. So what's the source of their pain? I found it's usually old dissociated pain. You talk to an addict or an alcoholic, ask them one question. When you use the substance, do you do it to get high or to stop feeling terrible? Most of them will tell you it's to stop feeling terrible. Okay, so where's that terrible feeling coming from? Well, it's usually old dissociated pain. You got to get rid of it, or they'll just switch from one addiction to another. I had one guy tell me that he was really great with 12-step programs. He'd overcome like 10 different addictions. Well, he went from one to the other. You know, he just kept bouncing around. Okay, you get rid of the pain, they don't need the addictions anymore. The addictions go away. Obsessive thoughts and compulsive behaviors can serve the same purpose. If I distract myself, or if I stay one step ahead of the anxiety by staying busy, I won't feel it as much. Somatoform disorder. Dr. Putnam wrote, somatization, that is recurrent multiple physical complaints without an apparent medical cause, has been strongly associated with histories of childhood maltreatment in adult and child studies. When specific types of somatic complaints are examined, abuse histories are significantly more common in women with pelvic pain, gastrointestinal disease, and headaches, unquote. He goes on to say, quote, dissociation has been correlated with somatization in several studies. One study found that 64% of dissociated patients met DSM criteria for a somatoform disorder. It's commonly referred to as a body memory. I had a client once a lady who complained about severe uterine pain. Well, the only problem was she didn't have a uterus. She'd had a complete hysterectomy at one point. Well, it found out she had an ulcer in there who had absorbed severe uterine pain at one point. I'm not sure what was causing it. But anytime that ulcer would come up close to the surface, she would feel that severe uterine pain. And when the ulcer moved in the background, she didn't feel it anymore. Get the ulcer to tell the story, get rid of the pain, she didn't feel it anymore. The problem went away. Her psychiatrist told, or her doctor told her it was all in her head. Well, yeah, sort of. Okay, schizophrenia. On page 529 of the DSM-4, it states, quote, the presence, under the heading of dissociative disorders, the presence of more than one dissociated personality state may be mistaken for a delusion, or communication from one identity to another may be mistaken for an auditory hallucination, leading to confusion with the psychotic disorders. So they admit in the DSM-4 that schizophrenia can be misdiagnosed, or the dissociative disorder can be misdiagnosed as schizophrenia. Talked to a lady one time, she was finishing up a PhD in psychology at UCR in Riverside, and she was doing an associateship. She was getting some hours at the office I was in. And I asked her one time, I said, do people who have dissociative disorders ever be misdiagnosed with schizophrenia? She said, oh yeah, it happens all the time. I'm going, geez, okay. Colin Ross in the trauma model says, quote, within the trauma model, both schizophrenia itself and psychotic symptoms in general are highly trauma-driven. Also, positive symptoms of schizophrenia, including auditory hallucinations, are actually more common in dissociative identity disorder than schizophrenia. A higher percentage of multiple personality cases than schizophrenia cases report one or more Snyderian first-rank symptoms of schizophrenia. As well, the average number of Snyderian symptoms per patient is higher in multiple personality disorder than schizophrenia. Okay, so if a person who has a dissociative disorder goes in to see the psychiatrist and he has more symptoms of schizophrenia than a schizophrenic, what's the probable diagnosis? Okay, add to that, therapists don't really know how to diagnose a dissociative disorder or recognize it, and it's no wonder it takes 7 years to get an accurate diagnosis. Okay, during those 7 years, again, the client is misdiagnosed and mistreated. Colin Ross has set up inpatient programs in 3 psychiatric hospitals around the country. One's in Torrance, one's in, I think, Dallas, and the other one I think is in Minnesota or somewhere. It's an M state. He reports, quote, the average patients in our program has met criteria for 14 different psychiatric disorders lifetime, unquote. That's a lot of misdiagnosing. Again, Bessel van der Kolk, if therapists do not recognize the dissociative nature of traumatized patients, it will be hard to help them. Okay, we'll go back a little bit to bipolar. Page 529, DSM-4, goes on to say, and shifts between identity states may be confused with cyclical mood fluctuations leading to confusion with bipolar disorder, unquote. So they're saying that dissociative disorders can also be misdiagnosed as a bipolar disorder. Okay, Okay, I would suggest that all of your schizophrenic and bipolar clients be assessed for a dissociative disorder, either as a possible cause of their condition or as a comorbid condition. Personality disorders, DSM-4 definition, quote, an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment, unquote. Can you see how a dissociated person with several different personalities of different ages, in intense emotional pain, being triggered by a variety of external cues, each with their own set ways of reacting, could be labeled with a personality disorder? Okay? There are three primary sources for depression that I'm aware of: situational, chemical imbalance, and a reservoir of old depression, usually dissociated. When a bipolar client comes in, is on meds, and is still depressed, to me that's a red flag. I assess for a dissociative disorder, which is usually what's going on there. Now after we clear that up, magically the medication's working. Well, it always was. It was taking care of the situational and the chemical imbalance, but it usually doesn't touch dissociated depression or anxiety, that kind of a thing. Let's see, Dr. Putnam, quote, blackouts and time loss in the absence of substance abuse or organic problems are hallmarks of dissociative pathology, unquote. So if you have a client that has blackouts, they're losing time, that kind of a thing, that's a red flag. People are not remembering, people not remembering something they say or do can account for time passing, or they wake up in the middle of something and not remembering how they got there, are examples. I had a client once who, at the end of treatment, told me that she couldn't believe how long a day was. She'd had an alter who had come out and taken over part of her day for years, but she just couldn't believe how long a day was. Okay, aggression, according to Dr. Putnam, quote, numerous studies have linked histories of physical abuse to aggression. I think it's clear that maltreatment, particularly physical abuse, makes a significant contribution to conduct problems and antisocial behavior, unquote. Being abused makes people angry, you know. If a person has no outlet to express that anger, like they're a child who's not allowed to demonstrate or express any anger and they're being physically abused, it's going to build up and dissociate, later showing up as explosive rage that the person can't control, or conduct disorders or antisocial problems. Almost all the clients I've worked with who have had anger management issues had dissociated anger that we were able to discharge. Trauma is a common factor in most disorders. Colin Ross put it this way, quote, trauma affects the onset, symptomatology, comorbidity, course, and response to psychotherapy, psychopharmacology, and outcomes of all disorders in the DSM-4, unquote. The worse the trauma, the more severe the symptoms, the longer they're going to persist. He suggested if psychiatrists would add trauma therapy to their medication regimen, they'd get a lot better results. And that's been my experience as well. Dr. Putnam claims, quote, the wide variety of symptoms commonly found in MPD includes most of the types of symptoms found in all of the other psychiatric disorders combined, unquote. Okay, if the symptoms of DID are the same as the symptoms in all of the other DSM-4 disorders, could there be a cause and effect relationship? Could it be that dissociated pain, which causes dissociative disorders, can also cause other DSM-4 disorders, or at the very least aggravate them? Okay, perhaps some DSM-4 disorders are creative ways to cope with dissociated pain. Colin Ross in the trauma model says, quote, the problem is not the problem, it is the solution to some other problem. The diagnosis is usually a coping strategy and not the problem in and of itself. Bessel van der Kolk claims histories of childhood trauma are often found in patients who are diagnosed with borderline personality disorder, affective disorders, somatization disorder, dissociative disorder, self-mutilation, eating disorders, and substance abuse. One central element of all these conditions have in common is the high prevalence of dissociation, unquote. Okay, things that don't help. Electroconvulsive shock therapy, it's a lot like abuse. Behavior modification, it's controlling and too much like abuse. Assertive aversive condition, it's too much like abuse. Most drugs, especially antipsychotics, it stops the voices and the healing. We want internal dialogue going on. Exorcism, you can't get an alter to go away. Misdiagnosis and subsequent mistreatment is not helpful. Denial is also not helpful. Alters really do exist. They are in pain and they need help. And they don't want you to know they're there, so they're going to hide. Dissociation is all about avoidance. Avoid the pain, avoid being known, avoid situations, avoid. Trauma conversion therapy it's a simple four-step process. 1, set up a communication with the internal system using the subconscious mind, using a deep relaxation and an ideomotor response, just a finger response. 2, alters remember and share internally all of their painful memories. That releases the pain. The alters grow up. 3, the alters grow up or catch up to the age of the body. Number 4, the system is rejoined or reintegrated. That's it. It's a real simple process. Okay, to summarize, trauma causes pain. Talking about trauma releases pain. Unprocessed pain stays stuck inside. Old pain produces DSM-4 symptoms. The one who absorbed the pain has to tell the story. In dissociative disorders, the alters are the ones who are stuck with the pain. The alters are the ones who need to tell the story. What is curative in dissociative disorders is alters telling the story. What is curative in PTSD is the alters telling the story. Most people know that talking about painful things helps to feel better. The essence of this technique is a simple statement made by David Viscott, MD. The healing begins when the truth is spoken. Real simple, elegant way to express it. When alters tell the story, what happened and how they felt. If they just talk about what happened, it doesn't do any good. Identify the memory and the feelings connected to the memory. I dropped a rock on my foot, hurt like heck, really ticked me off. That's as complicated as it needs to be. When the alters tell the story, the pain goes away. And that by telling the story, what happened, how they felt, that converts the trauma into memory. That releases the pain. It converts the trauma into memory. And it goes away. It goes away permanently. It sets the prisoners free. It's not just the client who feels like a prisoner. Every one of the alters inside feels like a prisoner. And you give them some hope and give them the opportunity to be free of this pain. They feel like they've been prisoners set free. Anyone who has a trauma history has a potential for dissociation, dissociated pain, and a dissociative disorder. If your client has a dissociative disorder, you do not want to miss it, or you will severely limit their ability to recover. I believe all clients with trauma history should be assessed for a dissociative disorder and PTSD. Again, it's been my clinical experience over the last 20 years that when PTSD is treated as a dissociative disorder, it can be healed. Now, I have a 26-minute video clip of a typical session. This is a 23-year-old woman, if we can get it to work. It's a 23-year-old woman who has all the classic PTSD symptoms. The biggest thing that's getting her into trouble is that when she gets drunk, she goes berserko. Yes?
What do you see as the most central reason that the alter is willing to open up and slow?
Because I sneak up on them. If I tell them I'm coming, they'll close down the system and I won't get in. I think that's demonstrated here. Let's watch this. There should be about 15 minutes or so at the end for questions. I'll be hanging around also afterwards as well, so that you need to see your fingers. So we got to move it over somehow. Or if you can. Anyway, let's see what else. At this point, I've talked to her. I've done my intake during the first session. Made a list of problems that she has, and a list of goals. And then, her goals, what she wants to accomplish by treatment. At the end of the first session, I have a clear understanding of her history, where she's at, what kinds of symptoms and difficulties she's having, and then we made a list of goals. And I've joined her in support of these goals. So I work on the client's goals. I don't work on mine, I work on the client's goals. They buy into it a whole lot better that way. They're a lot more cooperative. And the alters inside are paying attention. They know what's going on. They hear, okay, we're going to get rid of depression and anxiety and anger and all that other stuff. So that should work. So let's do this. I've done the deep relaxation, and we're setting up an ideomotor response. It's a finger response with the subconscious mind, and we'll continue. We could probably kill the lights if that would make it a little bit easier, and then we'll take some questions. There's a part of the mind that's referred to as the subconscious mind. I like to call it the inner mind. It's a part of the mind that's aware of everything that's going on around you. It's also aware of what goes on inside the body. And it even controls some of the body processes. And it acts like a recorder. This records all that information and stores it a lot like a computer. What I'd like to do is I'd like to set up a communication with your inner mind. I'm just going to ask some simple yes or no type questions. I'd like for the inner mind to respond just by raising a finger. It'll feel kind of like a muscle twitch or a reflex response. It's not a big deal. And I'll just call you Shy for short. And Shy, I'd like for you just to be an observer. Just be in the background. Don't try to answer the questions or even think of what the answer might be. But just let the inner mind express itself freely. Again, I'm just going to ask some simple yes or no type questions. I'd like for the inner mind to respond just by raising a finger. I think we use the left hand. If the answer is a yes, I'd like for the inner mind to raise this finger. If it's a no, to raise this finger. So this will be a yes, this will be a no. Does the inner mind understand? Okay. Question of the inner mind: is the body relaxed enough that the inner mind can communicate easily? Question of the inner mind: is the body relaxed enough that the inner mind can communicate easily? Okay, let's go a little bit deeper. I'm going to count from 5 down to 0. As I count from 5 down to 0, I'd like for you just to let all the muscles of the body continue to relax. So that by the time I get, and I like for the inner mind to help deepen that relaxed feeling, so that by the time I get down to 0, all the muscles of the body will be so deeply relaxed that the inner mind will be able to communicate easily. 5, just let yourself go. Just let all the muscles of the body become more and more relaxed. 4, continuing to relax. Just let yourself go deeper and deeper into that pleasant, relaxed feeling. 3, going even deeper yet into that pleasant, relaxed feeling as you let all the muscles of the body become more and more relaxed. 2, continuing to relax, just letting all the muscles of the body continue to relax. 1, going much deeper yet into that pleasant, relaxed feeling as you let all the muscles of the body become more and more relaxed. And 0, extremely deep now, so deeply relaxed the inner mind will be able to communicate easily. Question of the inner mind, just using the finger response: is the body relaxed enough now that the inner mind can communicate easily? Okay, great. A couple of things I wanted to check on. 1, so I'm wondering whether or not Shy might have a reservoir of old emotional pain inside somewhere that's built up over the years. She hasn't been able to get rid of it completely, and it still leaks out at times, and she feels it on the outside. And it could be anything. It could be anxiety, it could be sadness, could be anger, frustration, could be lots of different things. Question of the inner mind: does Shy have a reservoir of old emotional pain inside somewhere like that? Okay. Question of the inner mind: is there a separate part of the system inside that's been stuck with that reservoir of old pain? Okay. Question of the inner mind: is there more than one separate part of the system inside that have been stuck with old pain? Okay. Has one of those separate parts been designated to be like a manager or a supervisor for the internal system? Okay. Is one of them perhaps a little more active than the others? think I saw both fingers on that one. Question of the inner mind, is one of those separate parts maybe a little more active than the others? Okay, all right. Tell you what, we'll designate that one to be the manager, and we'll use that term for lack of a better one. Question of the inner mind, is the manager awake? Okay, well, I need to talk to the manager because I know how to get rid of the old pain. This is really cool. She's going to love it. So I'm going to count to 3. At the count of 3, I'd like for the manager to be present, able to be up front, able to speak or use the finger response, whichever you prefer, without changing the relaxed state that you're in. 1, 2, 3. Manager, are you there? Hi, do you know who I am? Okay, good. I'm curious first of all about the kind of old pain you were stuck with. Were you stuck with any physical pain? Okay. Are you feeling that right now? Okay, I'm not sure if I saw movement. Manager, are you feeling the physical pain right now? Okay. I'd like for the inner mind to block out the physical pain that the manager's feeling. It's kind of distracting while we talk. And then let me know once you've done that just by raising the yes finger. Okay. Manager, is the physical pain blocked out now? Okay. I'd like for the inner mind to block out the physical pain that the manager's feeling. Just do whatever you need to do. Block it out for just a little while we talk. And let me know once you've done that just by raising the yes finger. Manager, is the physical pain blocked out now? Okay, great, thanks. Manager, were you stuck with any anger? Okay. Were you stuck with any sadness or depression? Okay. Were you stuck with any anxiety or fear? Okay. Were you stuck with any feelings of hurt? Okay. Any feelings of loneliness? Okay. Any guilt? Okay. Any shame or embarrassment? Okay. Dang, you got a lot. Wow. Would you like to get rid of that stuff? Okay, it's kind of a silly question actually. Let me first explain kind of my understanding about how systems end up being split like this, and then you can tell me whether or not it matches what your experience has been. Anybody, whether they're a child, a teenager, or an adult, if they get hit with some kind of pain or stress or trauma that's overwhelming to them, way more than their coping mechanisms can handle, they have 3 choices. They can die, they can go crazy, or they can split. Fortunately, the splitting is a survival mechanism that's built into the human mind. It allows people to survive stress or trauma that otherwise would kill the body or destroy the mind. It's a normal reaction to an abnormal situation. It's how healthy minds handle overwhelming stuff. Well, basically what happens is when that stress or trauma hits the individual and they start going into overwhelm, a piece of the personality breaks off inside and forms a new individual, kind of like how identical twins are formed in the physical world. When that part splits off, it absorbs whatever stress or trauma is there, including things like physical pain if there is some, strong emotions like anger, depression, anxiety, etc. And then they absorb some or all of the memory of the event. Then they separate themselves from the rest of the system, so the rest of the system can go on functioning fairly normally. They also tend to build a wall of insulation around themselves to protect the rest of the system from the pain they're stuck with. And they feel that pain 24 hours a day, 365 days a year. It just doesn't go away. It's always really big, and about the only relief they get is when they sleep. Manager, does that match pretty closely to what your experience has been? Okay. It's really very common. Probably about half the population has a split in the personality like that. It's not a big deal in that we understand it, we know how to fix it, it's 100% curable. It is a big deal in that it can create all kinds of difficulties in people's lives. It can affect thoughts, feelings, behaviors, pretty much everything. Well, the way to get rid of the old pain is really simple. All you need to do is tell your story. That's it. Just what happened and how you felt. It's important that you do both, though, what happened and how you felt. When you do that, it releases that old pain that actually leaves the system. You won't have to deal with it anymore, and neither will Shy. And this is really cool stuff. It always works. And it doesn't matter who you talk to. In fact, if you want, you could just talk to yourself inside. That's probably the quickest and cleanest way to do it anyway. Manager, would you be willing to tell your story to get rid of the old pain? Okay. Do you know what the story is? What it was that you absorbed? Okay. What we could do is have the inner mind round those memories up and then start telling you one at a time what they are. You could share them and get rid of the old pain that way. Would that be okay? Okay, great, thanks. And would you be comfortable doing that inside? Maybe just repeat it back to the inner mind when the inner mind tells you what it is. Okay, great. It goes way faster that way. It's almost like a computer downloading. I'd like for the inner mind to round up all of the manager's memories that have old pain connected to them, emotional and physical, and then start telling her what they are just one at a time. Just bring one up, let her share it, bring up the next one, let her share it. You don't need to stop in between. And then, manager, if you would, go ahead and share that inside, just quietly inside. Be sure and talk about what happened and how you felt. If something happened more than once, you can just lump them together and say, this is one of the kind of things that happened, this is how I felt. And then just let me know when you're done or get to a good place to stop just by raising the yes finger. Manager, have you been able to tell as much of the story as you remember now? Or at least what the inner mind brought up? Okay, great. Question of the inner mind, does the manager have any other memories that have old pain connected to them that have been buried or forgotten? Okay. Manager, apparently there's more there. Do you want to work on some more of that today? Okay, are you tired? Okay, that's enough for today? Okay, great. Well, thanks. I really appreciate you doing that. That's going to be a big help. Be aware that there's more memory there. So if you don't want to work on it in between sessions, feel free to do that. All you need to do is ask the inner mind to bring up another memory. You can share it and just kind of chip away at this stuff till it's all gone. So thank you. I really appreciate you doing that. And I appreciate you being there. And I mean that sincerely, because if you weren't there, Shai would not have survived. It's, it's literally true. So thank you for helping her survive and now helping her to heal. Manager, do you know about how old you are? Okay, I think I saw both fingers. Manager, do you know about how old you are? Okay, are you younger than Shai? Okay, are you younger than 15? Are you younger than 10? Okay, are you about 10? 11. Okay, back it up. Are you about 10? Okay, 11, 12, 13. Okay. All right, that's a good age. Another cool thing about telling the story, it not only releases the old pain, but it also unsticks you physically, so you can finish catching up to the body age-wise. And I think you'll really enjoy that. That's going to be a neat experience for you. Well, thank you, Manager. Again, I appreciate you doing that. That's going to be a big help. Manager, the old pain that you were stuck with, is that starting to go down a little bit now? Okay, good. Two things just happened. One is you just demonstrated this works. Telling the story actually releases the old pain. The second thing that happened is there's just been a huge shift in power inside. It used to be that the pain had power over you. Now you have power over the pain. You have the ability to get rid of every drop of it. So congratulations, you're in control of your own healing. You have the power now. Well, thank you, Manager. Any questions or concerns at this point? Okay. Are you aware of any other separate parts in there besides yourself? Okay. Do you guys ever talk? You do stuff together? I'd recommend that you do that. That's going to be helpful. Also, if there's anything you want inside, your own room, a horse, a chocolate factory, whatever. If there's anything you'd like to have inside, just ask the inner mind to make it for you. You can have anything you want in there. Just have the inner mind make it for you. Well, thanks. We'll check in with you again next time. Hopefully you'll be pain-free and a little bit older. Question of the inner mind. Are there other separate parts in there besides the Manager? Have they been listening into what we were doing today? Okay, great. Anybody else inside who would like to go ahead and get started on getting rid of the old pain that you were stuck with? Feel free to do that. I'll try to work with as many as I can next time. But feel free to do that. All you need to do is what the Manager did. Just talk about what happened. Tell your story, basically, what happened and how you felt. Just keep it simple. Just identify the memory and the feelings. When you've told as much of the story as you remember, check with the inner mind to see if there's any other memory there that was buried or forgotten. If there is, the inner mind can tell you what it is. You can share it and be done with it. Because everyone inside now knows how to do this. You now have the power to heal. So congratulations. This is going to be awesome. And it's going to help Shy tremendously. So, well, thank you. Question of the inner mind. Does the inner mind have any other suggestions for things that would be helpful for us to do today? Is there anything the inner mind would like to tell Shy at this time? Okay, great, thanks. All right, in the future when we do the relaxation exercise, I'll do just that first part. I'll just count from 1 to 10. When I count 1, you'll be able to relax all the muscles in your feet. Then as I count up to 10, you'll be able to move that relaxed feeling all the way up through your body. Then when I get to 10, I'll say the word sleep. And when I say sleep, then you'll fall into a deep sleep of total awareness, just like you are now. When you want to relax yourself, do basically the same thing. Just get comfortable, sit down or lie down, close your eyes, count from 1 to 10. When you count 1, you'll be able to relax all the muscles in your feet. Then as you count up to 10, you'll be able to move that relaxed feeling all the way up through your body. And when you get to 10, say the word relax. I'll use the word sleep, you use the word relax. When you count to 10 and say relax, you'll immediately fall into a deeply relaxed state, just like you are now. When you want to come out of it, just count to 5 and say wide awake. So to get into it, count to 10, say relax. To come out of it, count to 5 and say wide awake, and you'll wake right up. And the more you practice this, of course, the better you get at it. Let's go ahead and wake you up then. I'm going to count to 5. At the count of 5, I'd like for Shy to be wide awake and alert, feeling refreshed, remembering everything. 1, 2, 3, 4, 5. Wide Is that a little weird? That's what everybody says. Okay, what you have basically is just a garden variety dissociative disorder. There's been a splitting in the personality as a result of some kind of pain or stress or trauma that you went through. You familiar with the circuit breaker on a house? Okay, well, we have one in our mind. If we get hit with some kind of pain or stress or trauma that's overwhelming to us, way more than our coping mechanisms can handle, it trips the circuit breaker. A piece of the personality breaks off inside, forms a new individual, kind of like how identical twins are formed in the physical world. Well, that stress or trauma gets shunted off to that part, and they absorb it, which allows us to survive, to go on functioning fairly normally. But then they become stuck with it. They become a reservoir of old pain. Their whole purpose for being there is to protect you from the pain, but it works imperfectly at best. It's going to leak out anywhere from part of the time to all the time anyway. When that part's way back in the background, you're probably not feeling them at all. The closer they come to the foreground, the more strongly you're going to feel whatever it is they're feeling. Anger, anxiety, depression, whatever it might be. When they're all the way up front, then you're going to feel everything they're feeling. And it's always really big. Causes overreactions, panic attacks, explosive rage, and all that kind of stuff. What's curative is for them to tell the story. You could tell the story 100 times and not feel any better. They tell the story once and it's gone. I mean, you'd probably actually feel worse if you told it 100 times. They tell the story once and it's gone. That's actually what's curative. That's kind of what I focus on, is getting rid of old pain, by telling the story, releasing that stuff. The subconscious mind, the inner mind, it can't communicate with you when you're awake. It can communicate with you when you're asleep, but only symbolically through dreams. And you may or may not understand what it's trying to tell you. If you have the same dream over and over and over again, chances are it's trying to tell you something, but you're not understanding it. Now, when you're in the deeply relaxed state, that in-between state, you can actually carry on a two-way conversation with your inner mind. That's why I use it, because it gives you access to a tremendous amount of information, and there's a lot of power there. The human mind's kind of like an iceberg. The conscious part, that little chunk above water, the subconscious part's that huge chunk underneath the water. That's where most of the power of the human mind is. You tap into that, you speed up the healing process tremendously. I mean, it just goes really fast. Now, the manager, you don't have to be relaxed to talk to the manager. You can talk to her anytime. In fact, do that right now. Just quietly in your head say, "Manager, are you there?" See if you get a response. Yeah. Okay, got a response? Okay, so you can talk to her anytime. You don't have to be relaxed to do that. This is one of those situations where truth is stranger than fiction. Nobody could have made this stuff up. It's also one of those cases where the little voice in your head is real. And it's not really a voice per se, it's more like a thought talk. It's not like an external voice like the lamp is talking to you, that kind of thing. Have you heard that voice before? Has she communicated with you before?
Yeah.
Okay. Has that been a long time that's been going on?
Yeah. I guess.
Okay. Did you know what was going on, or did you think you were just kind of thinking to yourself?
I did, but I didn't.
Okay.
I could kind of feel my hand moving at points, and I didn't know why it was moving.
Oh, okay, while we were doing the relaxation? Yeah. Okay. That's your subconscious mind. Your inner mind is communicating. When you're in the deeply relaxed state, you can actually carry on a two-way conversation. It's really cool. Okay. Anyway, you're not crazy and you're not going to go crazy. Your mind has chosen the healthier route of splitting. I mean, this is a normal reaction to abnormal situations. It's how the human mind is supposed to function, to split and, compartmentalize, if you will, old pain. The way to get rid of the old pain is really simple. It's just each of the separate parts needs to tell their story. What happened, how they felt. The pain goes away. They grow up, catch up to the age of the body, and you're pretty much done. So it's a really simple process. It doesn't matter how many separate parts are in there, because the healing process is the same for each one. Just a matter of them finding their memories, talking about them, getting rid of the old pain. I'd like for you to practice the relaxation exercise. Just get comfortable, sit down or lie down, close your eyes, count from 1 to 10, start with your feet, and you'll be able to relax the muscles in your feet with 1, and then as you slowly count up to 10, just let that move all the way up through your body. When you get to 10, say relax. That'll get you into it. Just hang out there if you want, or go to sleep, or whatever you need to do. And then when you're done, just count to 5, say wide awake, and you'll wake right up. So count to 10, say relax to get into it. Count to 5, say wide awake to come out of it. If you use it to get to sleep, you don't need to count to 5 and say wide awake. You just wake up when you're done sleeping. That's about all I can think of. Any questions about this stuff?
No,
It's clear as mud?
I think so, yeah.
Okay, good. Does this explain a few things?
What do you mean?
Well, stuff that you've experienced?
Yeah. Just things I haven't really thought about in a long time.
Okay. Does it explain maybe some reactions or overreactions? The manager talking to you, that kind of thing?
Yeah.
Yeah, okay, cool. Yeah, this really is pretty easy. We'll hopefully be able to get you through this fairly quickly. The PTSD it's a dissociative disorder, and we can clean those up pretty quick. So, all right, well, good. Okay, lights. Average time, usually it takes an alter 3 to 5 minutes to tell their story. When they do it inside, if they do it out loud, it's going to take an hour, 2 hours, 3 hours. Excuse me. Should have had a drink of water. Questions?
So is the person who was shy aware of what the alter manager was talking about?
I don't know. I don't know if she was listening in or not.
Was she listening in?
I don't know.
Sometimes listen in or not.
Sometimes they do, sometimes they don't. And alters have a tendency to not want to tell the story because they're afraid that it's going to hurt the client if they tell the story. So you just have the inner mind tune her out, or make a what do you call it, a soundproof room inside where they can go in and talk and then nobody hears it. Particularly children who have been abused and threatened with death or worse, if they tell the story, well, they were threatened to, they don't tell the story to another person, but they didn't say, there's no prohibition against them telling themselves the story. So that works great. It overcomes that objection. Another question over here? Yes?
Have you worked with someone who does have fetal seizures where they get into non-responsive state pretty quickly from triggers or from just talking about or thinking about their trauma? Or without even, I have one who doesn't even have to be in a traumatized or having any triggers, she will focus with it. And can you work with them with that?
I haven't. I would be happy to. Because if it's a dissociative phenomenon, it's treated all the same way. I mean, it's very mechanical. You just, what I did today, I do that with other people, pretty much with everybody that I work with who's dealing with old trauma. Pseudoseizures, I don't have any specific experience with that, but it would be, I'd handle it the same way I do this. Set up a communication with the subconscious mind. Ask, is there a reservoir of old pain in there? Yes. Is there a separate part of the system inside that's been stuck with that reservoir of old pain? Yes. Is there more than one? Yes. Is there one that's essentially the manager?
It's possible maybe that the inner mind can hear something that the conscious mind is not. Because she can't hear me when we're in session with what's going on.
Yeah, she may be tuned out. Sure. Especially if it's a true DID. The difference between DID and dissociative disorder NOS is the strength of the amnestic boundaries between the alters and between the alters and the client. If they have a co-consciousness all the time, then it's just an NOS. If the client is tuned out when the alters are out, then it's a true DID.
Maybe you mentioned this. Do you have a screening process where you learn there are some people that are not good candidates for this, for whatever reason?
No. I don't screen to whether or not they're good candidates. I just do it and everybody responds. There's some people who come in and say, oh, I can't be relaxed, or I can't be hypnotized, or whatever. I said, okay. They usually go under the quickest. They're really simple stuff. I use 2 inductions. I used to use just 1, but I use 2 now. 1 is just a progressive muscle relaxation, count from 1 to 10, just have them move the relaxation up, and then a visualization, just a guided imagery thing, usually something at the beach. I find between the 2 that almost everybody becomes relaxed at that point. If they don't, they're really having a hard time, particularly if they're ADHD, then have them go home and practice, for a week or so and come back, and then usually they're able to do it the second time.
You said with children, how young? What's the age range?
A mature 6 or above, you can do a formal relaxation. Anything under than that, you basically just, all I do is I just talk to the alters. I ask the client, kid comes in, he's has a 5-year-old, 4-year-old, severe anger problems. He bites kids at school, he throws things, he breaks things, he yells, he's angry a lot. So while he's playing with blocks or something on the floor, I ask him silly questions like, are you married, and that sort of thing, just to kind of get him a little bit off balance, but establish a rapport. And while he's playing with blocks, I'll ask him, so do you have, is it any chance there's an angry part in there somewhere? And they usually nod his head, and then he slows down playing the blocks. And, well, can I talk to that angry part? And he nods his head, and then I just talk to the altar. You just go straight and talk to the altar. Don't do a formal relaxation. It's not as clean, it's not as complete, but it gets rid of the symptoms. It makes it so that the kid's not biting and fighting and that sort of a thing. So with little kids, they can't do a formal induction, a deep relaxation. They just don't have the cognitive ability, I guess, or vocabulary.
But with the young child, you have them talk to themselves or they talk to you?
Just have them talk inside. I don't want to hear it. And it goes way quicker. I don't have the time.
The child understands when you're saying talk to them.
Well, yeah, if I talk to the angry part, says, is the angry part there? Yes. Are you the angry part? And he nods his head. Do you get angry a lot? Yeah. Are you angry pretty much all the time? Yeah. Did some stuff happen to you that made you angry? Yeah. And I said, do you want to get rid of that stuff? And they go, yeah. I says, do you remember what happened? What caused this angry? Yeah. Just like it did with her. And then say, would you be willing to talk about it to get rid of the anger? Yeah. Would you be comfortable doing it inside? Just talk to yourself. Yeah. So okay, go ahead and do that. Just talk to yourself. What happened? How you felt? Let me know when you're done. Then 2 or 3 minutes goes by, and he nods his head. Said, did you talk about all that stuff? The anger's starting to go down. Awesome. You're doing a good job. And then ask if there are any other parts in there that have it, that have old pain, anger, depression, anxiety, whatever it might be. But it's a really simple process. Yes.
Is it going to require a little sedation for
No.
kids that are autistic?
I've worked with a couple of high-functioning autistics, and no, I don't need any sedation. Somebody who had a severe case of autism, I would have no idea what to do with them. Cognitively, they might not be able to do the work. If someone is deaf, I haven't worked with any deaf people. I don't think it would work, because after they close their eyes, how are you going to communicate with them? Or someone who's cognitively impaired. Or cognitively undeveloped yet, underdeveloped at that point. So there are some limitations, but the rest of the population's available. It works with males, with females, with different religions, different races, ethnicities, languages, and it works. This is a human condition. This is a human treatment. This works really, really well. Yes.
I'm wondering if the manager or whoever the party that goes through this trauma doesn't really give us point to the person who's functioning on the outside. How do they process that to make the scenes properly behaved?
How does the altar process it?
No, how does
The client?
individual, yeah.
Oh, okay. Most of the time they're aware that they've been abused and what the abuse was. They may not know all the details. They may not remember everything that happened. But that's the part that they absorbed, they need to talk about. So I get the client to talk about what they went through, and I have them do it internally as well, because I don't want to hear it, and I don't want to take the time. I'd rather they download in 3 minutes than an hour. It saves time. It's way more efficient. And it's a lot less traumatizing for the client. Now, if the altar is afraid to talk about it because they don't want the client to hear it, because they're afraid it's going to traumatize them further, then I just have the inner mind tune them out, so that they don't hear it. It's better if there's trauma that the client was not aware of or has completely forgotten that the altar wants to share with the client. I recommend they do it before. Go ahead and do it internally without letting the client know. Once the emotional charge is gone, then go ahead and share it with them. And at that point, the client will say, oh yeah, I remember that now. But they don't freak out. But the stuff that the client remembers, they need to process. Just talk about what happened, how you felt. That's all it is. There was a guy I had in my office a couple of weeks ago. I thought he was about 400 pounds, I think, something like that. He does not have a dissociative disorder, but he has all kinds of trauma symptoms. And so I just had him tell his own story, In this case, it's just repressed stuff, and it's not dissociated. It's just repressed stuff, things that he's absorbed. And so, he processed the stuff internally. It took about 10 minutes or so. And when he got done, he said, I feel like about 50 pounds of weight has just been lifted off of me. Cool. I don't understand the mechanism. All I know is it works. Next.
Just real quick, would the treatment be any different if the trauma they're going through is ongoing, not in the past?
Yeah, they're going to have to, well, they process it the same way, but they're going to have to process it every day, so that it doesn't build up again.
Because they're still doing a job where they're going through traumatic experiences.
Yeah. I'd suggest get a different job. Yes.
What about if someone has traumatic brain injury?
That complicates things. I've had a couple, and I've asked their subconscious mind, is the brain repairing? Is there actually damage there? Yes. Is the brain repairing itself? Yes. Can you speed it up? Yes. Speed it up. It seems to help. The TBI, pretty much everybody who has TBI is going to have PTSD. And it's interesting that there are more soldiers coming back having survived explosions and that kind of a thing, because of the body armor is way better than it used to be. It used to be that it would kill them. Then they wouldn't have the issue. But there are a lot of them coming back with TBI now and PTSD as a result. Yes.
So when they're, like you just mentioned too, and you said, well, you can have the manager or the inner voice talk to let the other one know. How do they do that on their own if they're counting to 10 and then the person's not conscious of what the inner person is saying, and then they're supposed to count 5 to wake back up?
Okay, for the client for the client to talk to connect with the subconscious mind, they have to be in a deeply relaxed state. In order for the client to talk to an alter, they don't have to be in a deeply relaxed state. For the alter to talk to the subconscious mind, they don't have to be in a deeply relaxed state. So if the client wants to talk to an alter and check in, how you doing? Any other memories come up? Is the old pain gone? Have you gotten any older? Maybe thank them for being there. They can do that without relaxing themselves. If the alter has told as much of the story as they remember and they want to process some more, they can just ask the inner mind any time and just say, is there any other memory there that I absorbed that I haven't processed, or that still has some pain connected to it? If the inner mind says yes, they can ask the inner mind, okay, tell me what it is. Then they can share it inside. And they can just do that on their own. It's interesting that I've had several clients who've come from out of state or Northern California or whatever, who have had a dissociative disorder. I'll do several sessions with them, over a week period or whatever, and send them home, get them started, and send them home. They come back a couple of months later, and it's amazing how much healing's been done in the process. It's like setting up a self-healing mechanism. Once one of the alters inside figures out how it's done, and the others see how it's done, and that they can get rid of the old pain without hurting anybody else, they're all for it, And if somebody's gone for like 2 or 3 months, they come back, they're usually pretty much done. It's fascinating stuff.
What kind of reaction do you get when you start this and they do not have dissociative and they don't have an alternate?
Okay. It doesn't disappoint me if somebody doesn't have a dissociative disorder. I'm okay with that. Probably 80 to 90% of the people who walk through my door and probably walking through your doors have a dissociative disorder. It's roughly 50% of the general population, in my opinion, and 80 to 90% of the people that come into your office. I don't tell them that I'm going to assess them for a dissociative disorder. We make a list of symptoms, and I ask them, any chance there might be some old pain in there driving some of this? Oh yeah, I got lots of old pain. Okay, well and then I just kind of introduce the idea, and we do the relaxation, check them out. If the inner mind says there are if it says there's a reservoir of old pain, but there's no separate parts inside, then I ask, is this stuff that the client absorbed and stuff down inside? Yes. Okay, so I just get the client to talk about it. While they're in the deeply relaxed state, process it internally, takes about 3 minutes, and then wake them up. Say, okay, if any other memories come up, go ahead and process them. If you have traumatic events in your life, strong emotional reactions to things, talk about them. And you don't have to do it out loud. Nobody has to hear it. It's not therapeutic for the therapist to hear the gory story. What's therapeutic is for the client to say it, or the alters to say it. But nobody has to hear it. And it doesn't have to be out loud. They can just do it in their head. which is what she did. They can just do it in their head. It releases the old pain. The alters grow up. They can be rejoined. You're done. The symptoms are gone. Because you're treating the cause of the symptoms. You're not just treating the symptoms. Someone over here.
So, okay, I couldn't see her fingers moving all the time. Was she nodding her head? Or do
No.
you, if they don't move anything, do you just assume they're saying something anyway?
I mean, as far as telling the story?
Right. When you would ask the manager a question, sometimes I couldn't tell.
The video froze.
Yeah, the
video was frozen.
Oh. Okay. Yeah, I sometimes it was hard. This is a lot bigger picture than when I'm sitting across from her, and sometimes, there are a couple of times I said, I'm not sure I saw a movement there. I did see it on the screen, but I didn't see it when I was working with her. So if there's no response, then I'll ask the inner mind basically what's going on. Who is that? Oh, that's my phone.
I had another question.
That's
At the end, do you try to integrate the alters, or do you allow the alters to stay?
Okay, what I tell, there's three main parts to the healing process. The first part is for the alters to tell the story. That gets rid of somewhere between their story, whatever they absorbed, what they remember and what they forgot. That gets rid of somewhere between most and all of the symptoms that people come in with. That's the most important part of the healing process. If that's all you do, huge improvement. The second part of the healing process is for each of the separate parts inside to catch up to the body age-wise. Usually when a part splits off, they stay stuck at the age the body was when they split off, and they don't start getting older until they start telling the story, but not always. Sometimes they actually split off older than the body. Those who are younger than the body when they tell the story, they tend to get older to match the age of the body. Those who are older tend to get younger to match the age of the body. As long as they're an adult, you're okay. The problem I've run into is if an alter is aging and they get stuck at a particular age, that usually indicates there's some other memory there that was overlooked. So you got to get the inner mind to dig it out, tell them what it is. They can process it and move on, so that they can finish catching up. Once the inner mind says all the memories have been brought up and shared, the alter says all the old pain is gone, and they've caught up to the age of the body. Now they're in a position where about a 99% chance that they're done, that they can safely reintegrate without having any further symptoms. So those are the three things that I look for. Yes?
There's nothing else in here specifically to raise the age or
Nope, it just happens on its own. Yeah, and they sort of go through developmental stages as they're aging, which is important. Because they may have missed out on something. Like if this alter is stuck at age 3, you may have a narcissistic personality disorder that you're dealing with. So if you have one of those, check to see if there's a 3-year-old in there. Because narcissism is a normal developmental stage. So whatever age an alter splits off at, that particular alter is stuck at that developmental stage. And so the process, them growing up, catching up to the age of the body is really important. Make sure that they get through that stuff, and they're not stuck at that particular developmental stage. Yes?
There's a condition, and I can't think of the name of it, but maybe somebody can help me out, where a person their bodily functions slow down, their speech, everything goes down. Anybody know what I'm saying?
Catatonic?
Catatonic thing.
Okay.
Have you worked with anyone like that?
I had one guy who was really, really interesting. He came in with a psychosis not otherwise specified kind of a thing, and there were some mornings he would wake up and he was frozen, he was stiff, he couldn't move, and it was really interesting. I'm not sure if it was an alter or what was going on. His psychiatrist said that it was kind of an intermittent catatonia. And okay, whatever that means. Anyway, he finally got rid of it. He had a dissociative disorder. We cleared that up. He had this psychotic diagnosis. He was still taking the medication. The voices were gone because for him, the voices were real. They were alters. And that's why so many dissociative disordered people are diagnosed with schizophrenia. Psychiatrist says, do you hear voices? They say yes. Oh, auditory hallucination, here's some antipsychotic medication. They don't ask the second question. Is the voice in your head, like thought talk, or is it an external voice like the lamp is talking to you? Most of the time, if it's inside the head, it's thought talk. Most of the time, if it's external, it's an auditory hallucination, but not always. So you have to sort that out. Anyway, catatonia, I haven't dealt with that other than this one individual, and it's gone.
So it would be safe to try some of this?
Sure. Yeah. Yeah, this, you can't hurt anybody using this. And doing a deep relaxation, you can't hurt them, you know. If this is your level of relaxation when you're awake and this is your level when you're asleep, the deeply relaxed state's somewhere in between. You go through it as you go to sleep, you go through it again as you wake up. It's a normal, natural condition that people experience every day, you know, and it can't hurt. And I've told people before that if, you know, we get you in the deep relaxed state and if I fall over dead, after a while you're either going to wake up or go to sleep, depending on how tired you are, you know, so it can't hurt. Yes?
Repeat the 3 steps again.
Which 3?
The altar tells the story.
Okay, yeah, okay. Altar tells the story. Okay, well, the 3 I'm thinking of are the altar tells the story, that gets rid of the old pain. Then they catch up to the age of the body. That further strengthens the system and adds a higher level of maturity. What number is that? 3? 3 minutes. Oh, no. Okay. And then rejoin the system. And rejoining is voluntary. They don't have to, but I give them I give them a good sales pitch to where they always do.
So do you have scripts written out, or what's the best way to learn how to do this?
You can go to my website. I've got a card there. Those of you who would like additional information about this, if you would either drop one of your business cards in the basket back there, or sign a name on the folder that's back there, the spiral notebook. That's what it's called. I'd be happy to talk to you about that some more. I do a training. I'm not supposed to promote a commercial venture here, but I'm set up as a CEU provider with the California Board of Behavioral Sciences. I have a 40-hour training that I do. It offers 40 CEUs. I checked with a guy at the licensing office here in town. They're willing to accept the Board of Behavioral Sciences authorized, what do you call them, providers for CEU credits for license renewal purposes. So yeah, I could do that. I haven't done any trainings here. I've done 4 in California, but all the therapists have been able to use it successfully. So it's the technique. It's not the therapist. So I offer that type of training. If you have somebody in this area who does that, you know, that would be great. How many at this point believe that or feel that you need some additional training in the diagnosis and treatment of dissociative disorders? Okay, that's way more than when I came in. I accomplished my goal. Please consider dissociative phenomenon in your clients. You may have dissociated pain hiding in your practice. It makes a world of difference for your clients. Annette Compton, the lady that I mentioned, that I share an office with, told me that she's doing way better therapy now than she's ever been able to do in the past. I taught this to a social worker in Hemet, and she says that she was frustrated with the therapy that she was doing because she wasn't really getting the results that she wanted. And she says now using this technique, she's getting all kinds of really good results. Even just teaching people the deep relaxation helps tremendously in being able to calm themselves down when they're having a panic attack, that kind of a thing. So thank you so much. I'll be here the rest of the day and tomorrow. If you have any other questions or give me a call, I'd be happy to give you my cell phone number if you want to call me. Anyway, I'm open for other questions, but thanks. I really appreciate you being here. It's been awesome.